All right. Can we start now?
Yeah,
Okay.
sure.
Okay. Assalamualaikum. A very good morning. I bid to Mr. Hamid and members of the floor. My name is Mahirah, and the other presenter is Emir. We will be discussing on the topic of gastrointestinal bleeding. So, as you all know, gastrointestinal bleeding is divided into two, which is the upper gastrointestinal bleeding and also the lower part. Okay, so we will be starting with the case presentation first. Okay, the case presentation here is Mr. Dave, a 64 years old teacher, presented to the emergency department with the complaint of vomiting of blood for 1 day. Okay, so the blood was about a day and about 3 episodes. Okay, the vomitus was only in a small amount. Claim is about half cup in measurement. Okay, otherwise the vomiting was not projectile. Okay, and Mr. Dave also claimed that the blood was dark red brownish in color. Okay, and there's no blood clot with no mucus in the vomitus. Okay, other than that, he also presented with epigastric pain, which happened slightly after the.
Okay.
Yes.
Proximity. Proximity. You continue. Talking to others.
Okay, so it is also associated with epigastric pain immediately after he vomits. And the character, and he said it is a pain, it is a sharp pain, non-radiating, no relieving of aggravating factor, and it is intermittent. And the pain score given was 6/10. Other than that, he also complained of nausea and dizziness after the first episode of vomiting. Otherwise, the bowel habits remain unchanged. Then there's no loss of appetite, no palpitation, no fever, no headache, no early satiety, no heartburn, no bitter taste in mouth, and no dysphagia, no loss of weight. Okay, after further questioning, he said that he smoked about 30 cigarettes for 45 years already, and then described himself as a social and occasional drinker of alcohol. Regularly 2 to 3 pints of beer once a week. So when we, upon examination, he is a man of a moderate build, lying supine on the bed with an IV cannula. In the vital signs was as stated. The pulse rate is about 83 beats per minute with regular volume, good rhythm and normal character. The respiratory rate was 18, but blood pressure was 122/61, and the temperature is 37. Pain score was 6/10. So from here we can see that the vital signs are normal, right? And then proceed to systemic examination. Okay, upon abdominal examination, the abdomen was soft, non-distended, tender over the epigastric region. Okay, no palpable mass. Liver was not enlarged. Spleen also not palpable, and kidney not palatable. Otherwise, other systemic examinations are normal. So from the history just now, we can see that the patient presented with vomiting with blood and also abdominal pain for 1 day and nausea and dizziness. So from this, we can do a differential diagnosis of the upper GI bleed causes. So we have here is the malignant and also the benign pathology. The malignant, we can say it is maybe gastric carcinoma or any hepatobiliary carcinoma because presented with epigastric pain where the pancreas is lying there, and also the pancreatic carcinoma. Other than that, the common one is going to be the peptic ulcer disease, chronic pancreatitis, and also gallstones. So here, we can say that the provisional diagnosis is peptic ulcer disease because of the points that we say the Mr. Dave presented with hematemesis, for 3 episodes, and there's intermittent epigastric pain, tenderness at the epigastrium, and also has anemic symptoms such as dizziness and nausea. So as an introduction to acute upper gastrointestinal bleeding, it is divided into varicose and also non-varicose. So for the varicose upper gastrointestinal bleeding, usually it is a complication of the liver disease, while the non-varicose part, it is associated with peptic ulcer or other causes. So actually, based on the guidelines in Malaysia, the static shows peptic ulcer remains the first factor for upper GI bleed. So here, we can see in the picture, the causes of upper GI bleed. There is varicose and non-varicose. So varicose bleeding divided into esophageal and gastric, while non-varicose, there's a lot of differentials under non-varicose bleeding. The most common one is peptic ulcer disease. So from the photo here, the picture in the slide showing varices happens in 10 to 20% of the population, and the gastric ulcer and duodenal ulcer comprises of 50% causes causing upper GI bleed. So from the history and also examination, we can actually distinguish the diagnosis, the differentials just now, based on the history that we got. So if we suspect the person having peptic ulcer bleeding, peptic ulcer disease, we can explore more on the history of any aspirin taken or any NSAIDs used or any inflammatory drug use associated with abdominal pain. And then if we suspect it is only gastritis, most likely the presentation is more or less the same as peptic ulcer disease. And if we want to suspect esophageal varices, maybe there's a what we call history of any liver disease, liver cirrhosis, or any hepatitis A or B, showing that there's a portal pressure causing the esophageal varices. Okay. Other than that, if the patient come to you with same presenting complaints, but there's repeated retching or vomiting, we can suspect. And also consumption of alcohol, increase in consumption of alcohol causing tear to the esophagus, we can suspect the patient have biliary waist tear syndrome. And then other than that, if there is history of weight loss, smoking, and alcohol consumption, we can also suspect gastric CA, right? Okay, and then other than that is less likely lah, such as arteriovenous malformation, deulophoid ulcer, and also esophagitis, which is less likely. Okay. So the first one is the peptic ulcer disease, which is the commonest cause. And peptic ulcer divided into duodenal and also gastric. But duodenal is more common than gastric ulcers due to the bacterial formation of the H. pylori in the duodenum. And then other risk factors for this peptic ulcer disease is the NSAIDs used, aspirin, steroids, smoking, and also traditional medicine use. And then for esophageal varices, okay, it happens, esophageal varices happens due to the increase of hepatic venous pressure more than 12 millimeter mercury. So when this happens, especially in liver cirrhosis patient or any hepatitis or any pathology to the liver, when the hepatic venous pressure gradient is more than 12 millimeter mercury, there's a tendency for the patient to develop esophageal varices. Okay. And then, okay, we come across to the clinical presentation of the upper gastrointestinal bleed. So patient will come to you and say, saya muntah darah lah doktor. So, and then we will be asking on the any melina, passing out melina, is it fresh or is it blackish? Okay. Other than that is the occult bleeding, which we cannot see the bleeding, but when we do the occult test, it is positive. So that is all. That is the history that you have to note it about upper gastrointestinal bleeding. Okay. Other than that is the symptoms of, because it's bleeding, right? So other than that is going to be the symptoms of anemia. So dizziness, syncope, palpitation, chest pain. Okay. That's the history that you have to ask. Okay. And then we also have to exclude history such as epistaxis or any hemoptysis. So we have to ask either chronic cough, so that we can rule out other GI source, other gastrointestinal source of bleeding. And then, okay, for past medical history, if a patient, like I said, if she or he came to you with hepatitis or any liver cirrhosis, there will be a huge suspect of they are having esophageal varices. For past surgical history, for example, if a patient went for splenectomy, they have the tendency to have upper gastrointestinal bleeding also, because during the splenectomy, the gastric vessels is somehow ruptured. So after getting the total history, we proceed with the examination. So because the patient came to you with bleeding, so in your mind, you have to always note that, is the patient in shock? Because bleeding can cause shock, okay? And we can also see other skin changes to suspect like cirrhosis, maybe that's from erythema, like you see in the diagram, or the patient having bleeding disorders causing upper GI bleed, okay? And then signs of shock, such as signs of dehydration. And upon DRE, we have to do DRE because we need to always exclude if there is any fresh blood or any melina. So approach to upper GI bleed. Since patient came to you with bleeding, so we have to really categorize the patient. Either the patient is in shock or not. So if the patient is in shock, we have to resuscitate the patient and then stabilize the hemodynamic status. And then we have to identify their source of bleeding and then stop. If there is an active bleeding, then I will share to you how do you want to know whether the patient have an active bleeding. And then we have to treat the underlying source and then prevent the recurrent bleeding. So to assess on the severity of bleeding, this is the category that we might use, which is minor, moderate, and massive. Somehow we can also use the grading, a shock grading, where there is a grade class 1, class 2, class 3, and class 4 for the shock classification. So from here, we can actually know if the vital signs when the patient came to you, the vital signs are normal, despite he or she having the bleeding, the upper gastrointestinal bleeding, we can assume that the blood loss is less than 10% of the total body weight. So we can classify into moderate and also massive. So if a patient in the massive bleeding severity, which is in shock, we have to resuscitate first the patient. So how do you want to know that the patient is in ongoing bleeding? So one of it is continuous hematemesis. Keep on vomit blood. So that is one of the signs that showing to you that the patient is in in an active bleeding. Other than that, is the persistent hypovolemic. Despite when you resuscitate the patient, still the vital signs doesn't pick up, and also passing of fresh melena or bright red visible clot. Okay, so this is the general management when the patient came to you. So we have to stabilize the patient using the SIP, basic management. We have to protect the airway, restore the circulation, and then identify the source of bleeding. So how to resuscitate the patient? Will be inserting 1 to 2 large bore cannula, okay, and then we will take blood, okay. Bear in mind, need to do the cross match because we don't know the patient might need blood transfusion, okay, and then monitor the urine output, watch for signs of fluid overload, and then if we suspect peptic ulcer disease, we have to give the intravenous proton pump inhibitor, omeprazole, 80 mg IV, followed by 8 mg per hour for 72 hours. And then we have to keep the patient nearby mouth for endoscopy. Okay, so when do we need to transfuse the patient? When the systolic, this is according to the CPG, when the systolic BP is less than 100 milliliter mercury, when there is presence of postural hypertension, when the patient gets up, he suddenly feels dizziness, and that is one of the indication for blood transfusion. And then pulse rate is more than 110. The HB level is less than 8 gram per deciliter. And in a patient with angina or cardiovascular disease, when the HB is less than 10 gram per deciliter, we have to transfuse the patient with Paxil. Other than that, when do you have to give fresh version plasma? It's when the INR is 1.5 times the normal reading. So usually the normal reading is less than 2, so it is more 1.5 times more than normal. And then when do you have to transfuse platelet? And when the platelet count is less than 50,000 mm3. So moving on to the, after we have cut the patient, do the physical examination, we'll be moving on to the investigations, right? So of course, when the patient bleeds, you have to take the full blood count because you want to know whether the HB levels is at what level. And then you have to know whether the patient is in septic shock or not. So we have to take the, we would like to see the white cell count. And then the coagulation profile, whether the patient might have coagulation disorders, we do not know. And then liver function test, renal profile, and also blood group and cross-match for blood transfusion. So if you another one, if we suspect the patient have peptic ulcer disease, we also need to do the Campylobacter-like organism test. So if the test is positive, we straight away need to do the eradication therapy after completing the PPI infusion that I said just now, the 80 milligram omeprazole. And then if the Campylobacter-like organism test is negative, we have to repeat the test later. Other than that, chest X-ray is also needed, okay, to look to exclude any aspiration pneumonia or any effusion, and then to look for any gas air under diaphragm if there is a perforated peptic ulcer. So, okay, moving on. Okay, so when we have resuscitated the patient and then we have decided that, for example, we have decided that the diagnosis is peptic ulcer disease and there is bleeding in the upper gastrointestinal bleed, we would like to do the endoscopy, the OGDS. So according to the guideline, we are supposed to do the endoscopy within 24 hours of presentation, meaning within 24 hours of patient presented to us, we have to do the endoscopy to identify which part of the upper GI bleed that is bleeding. Okay. So this endoscopy is diagnostic and also therapeutic. So before the procedure, take the consent and then give the eye therapy and then proceed with the endoscopy. So for peptic ulcer disease, when we do the OGDS, okay, the endoscopy, we can classify the staging of the ulcer. So we use the Forest classification. We have the Forest 1A, 1B, 2A, 2B, 2C, and also 3. So we use the acronym SOVA. So stands for spurting hemorrhage for 1A, O, oozing hemorrhage, and then V, visible vessel, A is adherent clot, H for hematine covered lesion, and then last one is the Forest 3, which is there's no sign of hemorrhage. You can see a clean ulcer base. And then if we do the endoscopy and then we suspect esophageal varices, we classify it into Japanese classification, which is the grade 1, grade 2, and also grade 3. So by grade 1, we can see that this only a small straight varices, okay, that does not appear on insultation. While grade 2, it only occupy less than 1/3 of the lumen, while grade 3, more than 1/3 of the lumen of the esophagus. So actually, when doing the endoscopy, if we suspect that the patient having active bleeding, we can stop straight away the bleeding by using these examples of treatment modalities. So we have 3 types of it: injection, thermal, and also mechanical therapy. So for injection, usually if you see, we will inject adrenaline, okay, that acts as a vasoconstrictor to stop the bleeding. And other than that, we have sclerosants, procoagulants, and also cyanocrylate glue. So these are actually the examples of what you can do to stop the bleeding. And then based on the studies, it shows that combination therapy, which is adrenaline combined with any of these other therapies, is more more prominent in treating the in stopping the bleeding. So we suggest to do the combination therapy. So this is the example of the picture on how you do the epinephrine, the adrenaline injection. So you can see that this is the gastric cancer. Okay, so this is a sclerotherapy needle where we inject the epinephrine here to stop the bleeding. Okay. And then if for varicose bleeding, which is the esophageal and also gastric varicose bleeding, we use the pharmacological therapy. We could use the octreotide, where it will cause vasoconstriction and will decrease the portal flow and pressure to the varices now, and also telepressin. So this is how we use the varicose bleeding now. So if a patient came to you and you suspect the patient having esophageal varices bleeding, if you're at the district hospital where you don't have a proper management, you can always do a definitive management first, where we'll be doing the bending or the scleropathy. Okay, we bend first the varicose bleeding. And then we can also do the balloon tamponade, where we insert the balloon through the upper GI tract. Okay, as you can see in the picture, this is the esophageal balloon and also the gastric balloon. Okay, this is just a definitive management before you send the patient to the tertiary center for further management. For the transjugular intrahepatic portosystemic shunt, we are not practicing this currently. Okay. So after we had done the endoscopy, so it will turn up to you whether there's a D1 or D2 ulcer, forest type, berapa. So from that, we can manage the patient. So after doing the endoscopy, we must bear in mind that we have to give the proton pump inhibitor infusion for a high risk stigmata of peptic ulcer disease. Okay, we give it as IV bolus 80 milligram, and then continue by high dosage of 8 milligram per hour for 72 hours. It is a must for us to do this so that we can control the bleeding and And if the patient, when we do the Campylobacter test just now, and it is tested positive for H. pylori, we need to give the triple therapy, okay, which is the proton pump inhibitor plus amoxicillin plus clarithromycin for 14 days. Okay, it is a must for us to do this if the SELO test is positive. And then after after we done the endoscopy and give the endoscopic treatment such as adrenaline or clipping methods or thermal methods, we always need to monitor the patient in the ward. So because there's always risk of rebleeding. Okay, so how do you monitor whether your procedure before that is a success? So you have to monitor the vital signs, the
Mahirah, Mr Suraimi
yeah.
nak tanya soalan. Mr Suraimi minta buka mic Ada button microphone untuk Mr Suraimi dekat bawah tu. Turn on the audio.
The audio lah. Kamera tak payah on pun tak apa dah.
Oh, tak apa.
Okey, Mahirah.
Saya.
Assalamualaikum.
Waalaikumsalam.
Nice presentation, nice preparation, very good. One thing that I would like to give a comment is that when you mention about the use of adrenaline to stop the bleeding,
Yes.
and then you mentioned that we use by using the adrenaline, this adrenaline will cause vasoconstriction and will stop the bleeding, isn't it?
Yes.
Okay, but the truth is, okay, using the adrenaline to stop the bleeding is not because of vasoconstriction. Okay, beside the adrenaline, we can also use we can even use a normal saline to stop the bleeding. So meaning to say that the mechanism to stop the bleeding here is not because of the vasoconstriction. Sebab tu kita guna saline pun bleeding tu boleh stop. Okay, so the mechanism of action of injection is not because of the vasoconstriction. The mechanism of action of the injection is because of the tamponade effect given by the injecting fluid. That is the mechanism of action, not because of the vasoconstriction. Okay, so I hope that you can share this with all the housemen, all the audience today. Not to say that your statement is wrong, but it is not right. So because the mechanism of action is basically because of the tamponade effect. Okay, alright. So please carry on.
Mister, kalau tamponade effect tu maksudnya dia just is it how what do you mean by tamponade effect?
The effect ni macam kita give a compression lah. Okay, let's say you have a bleeding on the skin, and then you give a compression to stop the bleeding, isn't it? So for the upper GI bleeding, when there's a bleeding, especially usually the bleeding is from the gastroduodenal artery. By injecting the adrenaline or injecting the normal saline, this will this basically will compress on, will give a compression on the gastroduodenal artery, so that we can minimize and hopefully we can stop the bleeding.
Oh, all right. Understand.
Mm.
Okay.
All right.
Thank you,
Okay.
Mrs. Raimi.
Okay, please carry on. Okay. All right.
Okay. Moving on. So patient also, we might need to repeat the endoscopic done if the rebleeding occurs. Okay. Okay, that one. And then for varicose bleeding, which is the esophageal and also gastric varicose bleeding, the post-endoscopy management, we have to give antibiotic prophylaxis. So what kind of antibiotic that will be given usually is the third generation cephalosporin, okay, for a minimum of 7 days, because when esophageal varices happen, there's always a chance of infection to happen into the gastrointestinal. Okay. Other than that, for the secondary prophylaxis, we can also give non-selective beta blockers, plus minus the nitrates, and then for surveillance of HGDS, we will do and bending. We will do it every 2 to 3 weeks until the varices is eradicated. So for both of these varicose bleeding, we have to follow up the patient, especially for the management of the underlying of the chronic liver disease. Okay. So when do we have to do surgery in upper GI bleed? So there's 3 indications here. When the patient is in a severe life-threatening hemorrhage and it is not responsive to the resuscitation that we have given. Okay, so when we resusc the patient, dah bagi bola semua, dah transfuse, still patient tak responsive, it is an indication showing we have to go in. Okay. Other than that is when we fail for the endoscopic, the OGDS just now, and also when there is obstruction or perforation of the peptic ulcer. So the take-home messages from me for the upper GI bleed, always assess the patient first. When a patient comes to you with bleeding, assess the patient. So ABC is the first step, and then consider blood transfusion, okay? And then we have to do an early endoscopy. And then all patients with a high risk of peptic ulcer disease, we have to give the proton pump inhibitor infusion. And lastly, ingat yang the first line of H. pylori infection is the triple therapy, which is the proton pump inhibitor, amoxicillin, and also clarithromycin. You have to give to the patient for 10 to 14 days. So I think that's all from me. We'll be moving to the lower GI.
Yeah, Assalamualaikum and good afternoon. So my name is Emir Amshah, presenter.
Before Mahirah, dengar tak?
Dengar.
Can you hear me?
Yes, yes.
Before go to lower GI, kita settlekan upper GI dulu. Anyone ada question tak from audience? Faham ke? Atau tak faham? Okay. Just okay lah. Kita settlekan your lower GI, then I summarize everything lah. Sebab semua tak ada yang faham. Go, proceed Amjad.
Okay, lower gastrointestinal bleeding. So the definition of the lower GIT bleeding is the blood loss of recent onset originating from a site distal to the ligament of Treece. Nampak cursor saya? This one is ligament of Treece. Is usually suspected when patient complain of hematochezia, passage of a maroon or bright red blood or blood clot per rectum. So this usually patient will complain of the passing blood per rectum. For example, 67-year-old male patient present to the emergency department complaining of the passing blood per rectum for 2 days. So from the history, so we need to ask, is this the first episode of recurrent? What are the features of this bleeding per rectum? Is it altered or fresh, mixed with stool or not? Associated with the mucus, diarrhea, is it constipation? Needs to estimate the amount. Any abdominal associated with the abdominal pain or other abdominal symptom, any anal pain, any past history of the GIT or liver disease, or any anticoagulant medication. So the maroon stool with lower GIT bleeding is usually come from the right side of the colon. Bright red blood per rectum with lower GIT bleeding usually come from the left side of the colon. Colonic, if they come from the colon, is mixed with stool. If come from the rectum, usually not mixed. Another source of the bleeding is always bright red, not mixed, and streaky over the stool or dribbles only after the evacuation. And melena or current jelly stool, which usually come from the cecal bleeding or upper GIT bleeding. Always be careful about the bright red blood per rectum in the brisk and massive upper GIT bleeding. So the classification of the common cause of lower GIT bleeding, usually infectious colitis with like a Shigella, E. coli, or inflammatory bowel disease or colitis. Benign colonic, for example, diverticulosis or polyps. Malignant colonic must be excluded. Vascular malformations, for example, angiodysplasia. Benign anal pathology, for example, hemorrhoid or anal fissures. Malignant anal pathologies and drug-related, for example, anticoagulant or antibiotics chemotherapy. So come back to the history. The patient admit passing bright red blood mixed with stool. He usually opens bowel every 2 days. He denies any abdominal pain, but he get occasionally discomfort at left iliac fossa. His appetite and weight are steady. So no loss of appetite, no loss of weight. After passing to motion of stool mixed with blood yesterday, he today start passing pure blood with crampy pain and become so tired with was frightening to him, so he rushed to the A&E department. So from the history alone, usually most likely it is a left-sided colonic bleeding. For the differential is usually diverticular disease of the colon. Second differential diagnosis is colonic polyps, and third must be exclude colonic colorectal carcinoma. So after we get the thorough history and do the physical examination, state the vital sign, like Mahirah said before, take the blood pressure to look for the hypotension or not, take the pulse rate to look the patient tachycardia or not in case of the hypovolemic shock. Okay, then go to the ABC approach of your life. So the main problem in this situation or clinical scenario is circulatory problem. So must insert two large bore IV lines, then take the full blood count to look for the hemoglobin, then to look for the total white cell count, and coagulant screening, cross mesh, blood urea electrolytes, LFT also. So after insert the two last bore IV cannula, start the pistol, or can we straightforward to transfuse blood. So after resuscitation, monitor the vital signs. Then consider supplementary oxygen therapy and insert CBD to IO charting and G-tube to exclude massive upper GIT if the bile was obtained. So next, we do the parietal examination and proctoscopy. Colonoscopy must be done urgently, although most of the bleeding will stop spontaneously. Consider fresh frozen plasma or cryoprecipitate to correct the warfarin effect or other use anticoagulant, as Mahirah mentioned before. So this is a parietal examination. The first picture is show the anal fissures, and the second features show hemorrhoid. Usually hemorrhoid we can locate according to the site or clock. 3, the most common is 3, second is 7 and also 11 o'clock. Usually history from the coming from the alien fishes, a patient will complain about the parietal bleeding after evacuation, painful, and also itchiness, and also dia complain yang guna napkin tu akan ada blood lah per napkin. The second, which this is must exclude, this is anal cancer CA, and yang ni picture sebelah kanan ni adalah CA from the anus. So after see this, we need to take the biopsy to exclude the cancer. So colonoscopy, this bleeding, usually bleeding will stop spontaneously in 7 to 80 cases. Rebleeding can occur in up to 25 cases of patient. So colonoscopy is successful identify the site of severe lower GIT bleeding in approximately 74% of the patient. Colonoscopy offer diagnostic and also therapeutic intervention. The pictures shown here is a diverticular disease. So other features usually ulcerative colitis we can see in the colonoscopy, CA colon with bleeding, and also same also this is diverticulosis and Crohn disease. You can see goblet stone. So after we do consult, if fail to identify the source of bleeding, so we can do the imaging. For example, like CT angiography, second visceral angiography and embolizations. And next is nuclear med localization. I'm not sure if Shafiq did or not the nuclear med localization. So this is a CT angiogram. It's the arterial phase. How we know the arterial phase? We can see the contrast in the abdominal aorta. So we can see the extravasations dekat jejunum part. So on the right side is a magnification and interpretive projections. It's a extravasation of the branch of superior mesenteric artery at the source of bleeding. So CT angiography important is a non-invasive modality, allows a correct identification of the bleeding site and as well as the anatomic information. So CTA is a cost-effective, accurate, and rapid tool in diagnosis of acute lower GIT bleeding. Study report a pool sensitive of 85% to 89% and specificity of the CTA is 74% up to 97%. This second example of diverticular disease extravasations of the contrast at the CMOD colon showed by the CTA. They also same from bleeding from the diverticulum disease also. This in case of the angiodysplasia, we can see the nodular enhancement A and B of the wall in the distal ileum and early draining with vein. Okay. Next imaging we can do is if the CTA cannot be identified the location of the bleeding, so we can do the visceral angiography embolization. This visceral angiography can be positive if the bleeding is 1 mils per minute. So can see the picture of A, this superior mesenteric artery. We can see the extravasation of the contrast. So next we do the super selective imaging. So can see extravasation of the contrast for the superior mesenteric artery. Next, after we know the source of bleeding, we can do the embolization. In this case, we use the tornado microcoil. Then next, if the CT visceral angiography cannot be identified, we can do nuclear imaging in lower GIT bleeding. Usually we use the titanium, so we inject the titanium, and also this can be positive if the bleeding is 0.5 mil per minute. So if the positive in the nuclear imaging, it can be hint to the colonoscopy where of the site of the bleeding. So like Mahirah said just now, the surgical intervention in the case of usually lower GIT bleeding is stopped spontaneously after we resusc, after we give normal saline or give blood, but patient still having active bleeding, we can do the segmental colectomy if bleeding site identified and fail to stop or could not be embolized. Or if we cannot identify where is the location of the bleeding and also the patient still having a active bleeding, we can do the subtotal colectomy for an unidentifiable bleeding site. So this I put the criteria for a massive lower GIT bleeding as a life-threatening condition. Patient being pale and sweating, usually hemoglobin less than 6 gram per deciliter. Patient old, 65 years old. Systolic blood pressure below the 90 milligram per mercury. Presence of maroon stool or bright red blood from the rectum. Having other comorbidities, usually the cardiopulmonary mainly the comorbid. So that's from my presentations of lower GIT bleeding. So our preference usually come from reference. Sorry, is MESKIP, CPG guideline, and also Bailey and Love short practice and surgery textbook. Okay.
Okay. So management wise, both are covered. Okay. First of all, a good presentation by Mahirah and Amshar. Okay. First, before we carry on, Amshar, why very few HO attending the seminar?
Maybe because they are sharing the same.
But I don't know how many housements are available.
I'm not sure. Currently, housemate is 30. Huh? Currently, housemate is 30. Total housemate is 30. So maybe they are sharing the same email and also computer.
Oh, so how is attendance being taken for this? Ada ambil kedatangan tak?
We did not take any attendance because we just invite it in the group. Nak ambil.
So siapa HO, ketua HO Ketua HO siapa?
Hafiz.
HSO Hafiz.
Ah.
Okay. So he called all of them, get the names who are actually attending it now, then nanti bagi kat saya Khamis ni.
Alright.
Okay. Kita penat-penat buat this thing, we expect attendance. Okay. Sharing, I think most of us are all HOs, I think afford to ada smartphone kan. Tak perlulah nak share laptop ke, semua ada handphone canggih-canggih. I just saw one of my house officers tu ada iPhone 12. So I doubt that you all can't afford to get this. Okay. I'm just highlighting that, Dato mentioned that we are doing this is for you all. Okay.
Yeah.
So participation comes into your assessment. Alright.
Yeah.
Because last time individual kita tengok ramai-ramai, so only the surgeon who takes the houseman teaching tu dia yang tahu. Sekarang we are going virtual. So everybody will be in. So everybody will be watching. So your assessment and your will be affected by this lah. Alright. So please, since it's the first one we are doing, so I don't know lah. But for me, I think you all should back up in attending. This is for you all. Okay. One, to teach you all how to present. Number two, for your colleague to learn. They're sibuk. Dia tak ada masa nak baca buku semua. So when you do a presentation, you learn as you go on. Okay. So after this, I hope attendance are being taken and you are being watched. Okay. So all the consultants will join in and they will look into these things. Okay. All right. So back to your presentation, lower GI and upper GI bleeding. Okay. It's the most important. Okay. These are a surgical emergency. So when you leave as a house officer from a surgical department, you need to know how to manage a bleeding. Okay. It's a day in, day out punya ni. Okay. The idea that I presented asked for a case scenario, actually it's not for you all to present the case scenario. It's for you all to ask the participant. For me, teaching, I like to have two-way communication. It's not the presenter beritahu kat orang information, that's it. Everybody silent everything, just nak attendant, dia on chow. No, it's not supposed to be like that. It not meant to be like that. Okay, so kita ada another 20 more minutes. Mira, put your slide on your case scenarios. Alright, so who are there yang ada kat luar tu? The people. Nur Nadira is a husband, is it?
Yes.
Nadira, on your speaker. Nadira? Okay. So, a teacher comes with complaining of blood, small amount. What do you want to do?
First, we take a full history from the patient. First, in terms of color of the blood, and then amount, and is it first episode or not, and then we ask a risk factor for this patient, any history of usage of NSAID previously, and then underlying medical illness, and also medication history, such as aspirin or any other antiplatelet. And then do assessment for this patient in terms of general appearance, and also abdominal examination and rectal examination. From the general appearance, this patient looks tachycardic, and then septic looking, and also from the vital signs, pulse rate, BP, is it hypotensive, and also from the abdominal examination, any tenderness, palpable mass, and also from the most important one is digital rectal examination, any melena or fresh blood from the DRE.
Okay, so kalau BP dia 100/70, pulse rate dia 110. What do you want to do?
170, 110.
Pulse rate 110, BP 100/70.
170, pulse rate 170. Sorry. So
Systolic 100, diastolic 70.
Okay.
Pulse rate 107. 107.
So
Okay, what do you want to do now?
Pulse rate seems tachycardic, whereas BP more to lowish side. So first,
Lowish side.
I think
Tak ada highish.
Sorry.
Nadira, you're a doctor. So no highish, lowish. What is that?
BP normotensive.
Normotensive. 100/70 is normotensive, is it?
Sorry, hypotensive.
Yes, it's hypotensive. Okay.
So this patient seems to be in shock state condition. So we do a primary survey first, and then possibly.
Wait. You said shock. So what class of shock is this?
First look at the volume of bleeding. So I think if patient is
kalau kelas 2 baru naik, kelas 3 dia tak ada nak compensate.
I think maybe class 1 first.
Class 1.
Yes.
BP low, tachycardic. Kelas berapa?
Class 3.
Okay, at least 3. Okay, 2 or 3, at least 3. Alright, you start to have urine output low dah 3 dah. So at least 2 to 3. Okay, very good. So now what do you want to do?
So first we resuscitate this patient first.
Very good. Resuscitation. Okay, so how do you resuscitate this patient?
First, run IV bolus in 1 hour. And then once patient have been stabilized, so we proceed to the next step, which is to stop the bleeding. But before that, during the resuscitation, we take all the blood
Okay,
required.
Nadira, okay, stop. Nadira, stop. Nanti ni banyak tanya kan. Okay, Dr. Lee, is there on your speaker?
Yeah.
Dr. Lee.
Clear.
Jom. We can go long, tapi we need to, it's a public holiday, everybody wants to ni, so we'll try to wrap it up. Quick, Dr. Lee. Ada ke Dr. Lee? Tak wujud. Ni lah geng-geng yang key in, lepas tu speaker, lepas tu disappear. Shifa 25 ni siapa? Houseman. Dr. Shifa, are you there? Tak ada.
Mr. Hamid, I need to invite them to the stage for them to speak lah.
Invite
So,
lah. Kita nak two-way kan?
You need to respond I already invite Shifa.
Okay. Alright kan, Shifa?
Yes,
Please
Doctor.
invite all the ni. Alright, Shifa. So sekarang Nadira tu kata, what is that? Sorry, resuscitation. So how do you resuscitate a patient who is hypovolemic shock? Class 2-3.
Hypovolemic shock. First, I will start resuscitation with bolus. I will drip 20 cc per hour. 20 cc. Run bolus. And then monitor the electrolytes, ABG.
Hemorrhagic shock. Hemorrhagic shock resuscitation. Macam mana?
Hemorrhagic shock resuscitation. Resuscitation with 20 cc. And then monitor urine output. Assess clinical patient. Is a patient with pulse volume, 1.4, CRT, less than 2 seconds, and vital sign, monitor vital sign after resuscitation. And then monitor urine output at least 0.5 cc per kg per hour. And monitor lactate level.
Why lactate level?
For apa ni? Response of the resuscitation.
Oh, okay. You know, in district, y'all tak ada, y'all don't have lactate,
Okay.
So lactate is somehow, it's only available in the tertiary hospital. Alright, okay. But alright, lactate. Some more?
Monitor ABG.
Alright.
And then
What is your goal?
Lights. Okay. Lagi.
What's your goal of hemorrhagic shock resuscitation?
BP to achieve BP normotensive. And heart rate normal. And also good pulse pressure. And good urine output. And also
kalau tak achieve, once you given bolus, BP still bit better, pulse rate turun sikit je to 95, BP net 108/69. What do you want to do?
Continue resuscitation.
Sampai bila? sampai dia jadi normal. So the question is hemorrhagic, I highlight lah, hemorrhagic shock resuscitation. So bila hemorrhagic shock, maksudnya the shock is due to
Bleeding.
pandai pun.
Bleeding.
So sampai bila nak resuscitate? Sampai
Ada fat cell. Boleh transfer.
stop the bleeding. You have to find way to stop the bleeding.
Yes.
Okay. So acute resuscitation, get up the BP, but it will not be sustainable. So you have to find where is the source of the bleeding. You have to stop the source of bleeding. Okay, so that's why we mentioned about going for urgent OGDS. Then there are modalities how to stop the bleeding. So but if you don't stop the bleeding, then your tank will not be filled up. So when you talk about hemorrhagic shock, initial resuscitation with fluid, but you have to prepare the patient with group cross match and get blood. Okay, memang in every regardless ATLS ke survival sepsis care and everything all resuscitation memang with fluid, but if it's hemorrhagic, you have to get the blood in as fast as possible, especially in class 3 or class 4 shock. You don't resuscitate with fluid ongoing without blood. Sebab dia ada volume down, volume depleted. So dia punya tank dah depleted sebab the tap is open. Alright, so you need to fill up with blood, and at the same time you have to close the tap. Alright, so upper GI is very common, and most of the time they will come with hemodynamically instability. Okay, for lower GI bleeding, most of the time they are very slow ongoing bleed. They rarely come with massive bleed. So that's why it's commonly is a divertical bleed, angiodysplasia. Okay, the tumoral bleed is very, very less. Dia takkan datang profuse with tumor bleeding. Alright, and they will come more as a symptomatic anemia. Alright, or dia datang with fresh blood. So bila dia tengok fresh blood when BO, they'll be worried, concerned, and it's hemorrhoid. And most of the time, bleeding, dia self-limiting. Alright, unless if it's due to a big polyp ke apa-apa where you can polypectomy ke apa-apa, endoscopy, but diverticular 90% self-limiting. If it's hemodynamically instability or recurrent bleed, then you need to resect the respected bowel. Okay, the culprit tu kena buang. Alright, and if patient is high comorbids and everything, datang with ongoing bleed, then you have the interventional radiologist to embolize. So divertical bleed, kalau in the setting where you don't have interventional radiologist, you need surgical resection. If you have an interventional radiologist, then you do angioembolization. Okay, so where do we want to close already? So any questions from the floor or the speaker? Ada apa-apa nak tanya?
Mr. Hamid.
Ya, Mahirah.
In terms of the endoscopic management therapy, yang macam ada injection, ada clipping, so how to decide when to do adrenaline ke, just clipping or stapler?
Stapler.
How do?
Okay, tak ada stapler dalam endoscopy punya ni lah. Okay, so alright. If you see the guideline ni dia ada dua. For upper GI bleeding, dia non-variceal bleeding, variceal bleeding. Itu je you kena tahu. Bleeding upper GI is non-variceal or variceal. Alright, variceal totally different treatment, non-variceal totally different treatment. Variceal bleeding due to venous bleed. Non-variceal bleed is due to arterial bleed. Itu je you kena tahu. For basic lah. Alright. So for non-variceal bleeding is your injection, bending, then you give your whatever drugs you require. But for non-variceal bleeding, commonest is ulcer. Okay, 70% is due to ulcer. So when you do a treatment for ulcer bleeding, we find that you have to do dual therapy. Okay, dalam guideline dia kata dual therapy. Dulu dia ada monotherapy, lepas tu dia ada dual therapy. What are the dual therapy is any of the therapy. Injection, gold probe, diatomize, clip, okay, endoclot, these are advances of techniques they find. So if you do dual therapy, that means that you don't need a repeat OGDS. If you have monotherapy, okay, when do you decide to do which therapy, like what you say? It depends on the endoscopist, how comfortable the endoscopists are. Yang paling senang is injection. Sebabnya dia macam tamponade lah. Macam Mr. Zuraimi beritahu kan. Inform that the idea is tamponade. Just like you are going to press on top of the bleeding. Kalau you ada bleeding ke hand or anywhere you can see, you press. Isn't it? So you press to stop the bleeding. So that you compress the arterial, the artery to constrict so that flow reduce, your platelet aggravation, everything comes to do the hemostasis. All right. So then you have other modalities like clipping. Okay. So clipping is more challenging and you have to have skills. All right. Another modalities will be diathermy gold probe burn, and you have APCs, okay, argon plasma coagulation, and you have hemostatic powders to spray, either hemospray or endoclot. So you have to choose either one. It depends on the endoscopist punya ni. So ulcer which is at the duodenum, okay, sometimes it's very difficult to clip, okay, because of angulation and everything. So what the endoscopists prefer, they will inject and they put powder. All right. So if it becomes a dual therapy, then you no need to rescope back. But if you only inject, okay, patient tak stable, you inject, you cannot see clot and everything all. So what you do, you just inject, then you come back, okay, to reassess back, and then you do the treatment, either injection plus clip plus gold probe, or clip plus argon plasma spray, or so it has to be dual therapy. Any other therapy, tapi kena dua. Dia tak boleh satu. Kalau satu, the risk of rebleeding increases to 40 to 50%. So that's why you have to rescope. So bila ada forest classification, it's not only to tell you what type of ulcer bleed, but also the rate of rebleeding. If forest 3, it is less than 5%.
Less than 5%.
If forest 1A, it's 50%. So if you don't do dual therapy, you will definitely have to go in and you will bleed. And patient will be ongoing bleeding. So that's why you have dual therapy. Alright?
Alright.
Okay. So this is very important. Surgically, we see day in, day out on the bleeding, and also about resuscitation. So you have to identify upper GI bleed, lower GI bleed. How do you want to resuscitate the patient, and what are the options you have? Okay.
Alright.
Okay. Thank you very much.
Can I add something to this topic?
Boleh, Mr. Zain, please.
Yes, Mr.
Okay, regarding the resuscitation, of course, like what has been mentioned thoroughly by Mr. Hamid just now, but when we are doing the resuscitation in a bleeding patient, okay, so it is very difficult for us to get a normal, to get a normal tensive blood pressure and normal and patient which is not tachycardic.
Hello, Mr. Zuraimi.
Yes. Sorry. Dengar ke? Dengar ke tak dengar ni? Dengar ke tak dengar?
Dengar.
Hello?
Hello.
Saya boleh dengar je. Ada yang tak dengar?
Saya dengar.
Dengar ke tak? Dengar ke tak dengar?
Dengar.
Dengar. Okay, alright. Okay, so to achieve the normal blood pressure is some sort like impossible in the case of upper GI bleeding or lower GI bleeding. So there's a term that we also need to know. We also need to know, which is a permissive hypotensive. Okay, so during the resuscitation, before we are doing anything, of course, definitely concurrent to the resuscitation, we want to stop the bleeding. We want to do OGDS, or we want to do the surgery to stop the bleeding, isn't it? Okay. However, to get the normal to get the normal BP, it is quite impossible. Okay. So what is our aim during the episode of massive bleeding is, as much as possible, we would like to achieve the permissive hypotensive. Okay. So what are the parameters that we want to achieve during the permissive hypotensive? Number one, we want to achieve the systolic blood pressure of 90 millimeter mercury. Number one. Number two is we want to get the urine output of at least 0.5 mils per kg. And then number three, we want to get the blood. We want to get the heart rate of less than 90 beat per minute. So this is our target. This is our objective during the resuscitation. Before we can do anything, before we can do the OGDS, before we can do the surgery to the patient, which is having a hemorrhagic shock. Okay, all right.
Yeah. Thank you, Mr. Zuhaimi. Amirul, kita master student ada join dalam ni.
Master student.
Since we are going virtual, next time ask the master student, since I think Mr. Zuhaimi, Dato joining this thing, I think the master student should participate lah, because it's a basic topic, but we can ask them lah as part of teaching also lah.
So far ada seorang Azihan tu.
Oh, Azihan ada? Okey lah, tak apalah, sebab pukul 1 kan, cuti kan. Next time. Azihan, jaga. Lepas ni kita orang akan masuk, we will ask you also, because apa GI bleeding is a must for surgeon. Like macam Mr. Zuhaimi highlighted, permissive hypotensive is your level, you need to know. So you should come words, the key terminologies are must. Okay? Alright. Okay, thank you. Miro, anything? Just wrap up lah.
I think that's all good. Thank you so much for all presenter. Good job and congrats.
Okay, yeah, very good, Amirul.
Thank you, Mr. Hamid. Thank you, Mr.
Thank you, Mr. Hamid.
Thank you, Mr. Hamid.
Thank you, Dr. Amirul.
Okay, bye.
Thank you, Mr. Zuhaimi and all. Thank you so much.